Thank you again, and thank you for letting me move this talk up a little bit due to babysitting issues with my children. So we haven't yet talked about MDS yet, or non-transplanted and transplant therapies for MDS, but I'm going to cover a little bit of MDS in this transformation talk as well. So, so what is the definition of leukemic transformation? Many different disorders of the bone marrow can transform into acute leukemia, and the myeloid disorders can transform into acute myeloid leukemia. So MPNs that I just talked about can transform into accelerated phase or AP-MPNs, which is 10 to 19% blasts in the blood or marrow. And a blast is the sort of leukemic cell of this disease, or the cancer cell of this disease. And blast phase of these diseases is 20% or more blasts in the blood or marrow. And so it is very common to have low level of blasts in the blood. You might have noticed that on your own blood counts, particularly if you have fibrosis or scar tissue in the marrow. That is a marrow replacing process, and thus the blast, which is an early form of a white blood cell, is more easily able to travel in and out of the marrow and show up in the blood. And so in cases of chronic phase MPNs, we can see a few percent blasts in the blood because they're just easily traveling in or out. It's when they're accelerated is 10% or more, and blast phase is 20% or more. And then the myelodysplastic syndromes, or MDS, which you'll learn about shortly, can also progress. MDS typically has less than 20% blasts in the blood or marrow, and AML, again, out of MDS is when there are 20% or more blasts. So that's kind of the cutoff for leukemic transformation. And this transformation, it's just really just disease progression. There's nothing magical about this 20% number, is that it's often associated with acquisition of higher risk cytogenetic and mutational abnormalities. So someone might have had a JAK2 mutated MPN for many years, and then the stem cell acquires a higher risk mutation, and that can be associated with the risk of transformation. And this is an illustration of what those blast cells look like. They're sort of bigger versions of white blood cells. So how do people present, or how do you know if there's concern for transformation? So one is symptoms. Patients can have worsening constitutional symptoms, fatigue, fevers, weight loss, infections related to lowering of white blood count, and bleeding if the platelets are lower. And then labs, and this is something that we'll look for. We're always looking for when we are looking at your CBCs, is a rising white count. And of the differential on that white count, we'll often see something called blasts. Sometimes they're called immature cells, white blood cells. Sometimes they're called unclassified cells, or sometimes even decreasing white blood cell counts, or worsening anemia, worsening platelet counts. So worsening of all three cell lines. And so maybe patient has, you know it because the patient has been on a stable dose of Hydrea for 10 years. This is a really classic consult we get is, this patient has been on this dose of Hydrea for 10 years, and now in the same dose of Hydrea, all the blood counts are going down, or the patient doesn't need Hydrea anymore. And that's an indication to us that something is changing inside the marrow. And then the LDH is something that we look at as well. LDH is a really generic marker of inflammation, but it also can be high in chronic phase disease, particularly myelofibrosis. But if we see the LDH rising and rising and rising, that's another sign that we might have more active or transforming disease. So how do you diagnose it? Really, where the bone marrow biopsy, Dr. Caraway might like this phrase, blood counts don't come from the sky, was what my favorite mentor used to say, Dr. Esty. So where are the blood counts coming from? They're coming from the marrow. If we're seeing a change in the blood counts or in symptoms, we really have to go back to the marrow to know what's going on, to know if there is transformation. Sometimes if the blast count is high enough, you can do all your diagnostics just on the blood, because you can send what's called flow cytometry, which can identify blasts. You can send genetic and mutational testing from the blood. So that can be enough in some cases, but usually, particularly in the history of myelofibrosis, you want to know exactly what's going on in the marrow. You want to know the architecture of the marrow. And then pathologic evaluation, morphology, looking at the marrow. What does the marrow look like? How much fibrosis is there? How many blasts do we count when we look under the microscope? Flow cytometry. What are the surface characteristics of the blasts, particular to this patient? cytogenetics and FISH testing, and NGS or mutation testing, as we talked about. Even if you've had mutation testing at your original diagnosis, when you suspect progression, this is another time we always want mutational testing again, because as I said, usually you acquire new mutations when you progress, and we want to know that new profile. And then often we'll repeat spleen size evaluation, particularly if that is something that's a symptom for someone. So first we'll talk about MPNs in accelerated or blast phase. So I showed this earlier. In MPNs, we know how to deal with the short-term consequences, bleeding, thrombosis, symptoms. Do we know how to sort of prevent transformation to myelofibrosis or AML? We're not sure. Interferons may have a role, given that we know that they can lead to molecular remissions, although that has not clearly in clinical trials been tied to decreased risk of progression. And this is the risk of transformation to MPN or blast phase AML, about 5% in polycythemia vera, less than 5% in ET. This is probably closer to 1 or 2%. And myelofibrosis is higher, about 20% risk of transformation. So what are the outcomes of transformation? Generally, it is a challenging disease to treat. And that is because there are features, both of the chronic phase MPN that someone might have had for a long period of time, but also with new features of an aggressive disease. And so allogeneic stem cell transplant, which you just heard a little bit about, has the potential to be curative, but the risk of toxicity and relapse does remain high. And so we have many trials that are ongoing to attempt to decrease the risk of relapse and decrease morbidity. Another challenge here is that many patients are older when they transform and have leukemic transformation, both from MPNs and MDS. And as you just saw, age can be a challenging feature for transplantation. So for patients who are candidates, the most plausible curative option is transplant. But the trouble is we don't have an established therapeutic approach prior to transplant. We think that cytoreduction or reduction of blood counts and blasts can improve outcomes. And as you see on the right, this is just a graph of showing people who were transplanted in a CR, which is a complete remission in black, versus those that were not. The patients transplanted in a CR did better. But there's a really mixed result on the effect of blast percentages on the outcomes and which blast level you need to be below to go to transplant. So that is really a research question that's up in the air. It does take a while to set transplantation up, though. You need to be HLA typed and find a donor. Many patients are symptomatic, and the disease, leukemia, particularly if uncontrolled, can cause problems. So most patients do require some treatment before transplant. So what are our options? One are a group of chemotherapy or low-dose chemotherapy called hypomethylating agents, or HMAs, of which we have a few choices. Another option is intensive induction chemotherapy, we call it, which is the type of chemotherapy we would use for people who present with acute leukemia just up front. And then we can add targeted agents to the backbone of either lower dose or higher dose chemotherapy. These can be JAK inhibitors, or if someone's acquired a new mutation in our mutation testing, we do have other drugs for mutations, particularly mutations called FLT3 mutations or IDH mutations. Those are drugs that we have. And there's a new drug called venetoclax that I'll talk about. So what is our goal of therapy when MPN transforms? First, we still want to improve the manifestations of the underlying sort of chronic features of the disease. So we still want to improve splenomegaly, which is very symptomatic, and control people's B symptoms, the sweats, bone pain, and weight loss. And then secondarily, we want to put the sort of aggressive or a sort of leukemic portion of the disease into a remission. We want to eradicate blasts and restore hematopoiesis or normal blood count development, because it's those low blood counts that lead to symptoms. So blast reduction may be important for decreasing post-transplant relapse. As I said, the sort of cutoff for what blast percentage is acceptable is a little bit up in the air. And then restoration of normal blood counts in the absence of transplant is still important for decreasing infections, improving fatigue and quality of life, and decreasing transfusion need. So just because if you're not a transplant candidate doesn't mean we wouldn't treat you with chemotherapy to try to clear out the blasts of the marrow and improve blood count production. Combination therapy is therefore appealing to probably both target this chronic phase manifestations and the sort of leukemic portion of the disease. So this is a treatment paradigm that I like for MPNs in accelerated phase. So patients who have a good performance status and low comorbidity index, so not a lot of other medical problems. This one suggests induction or intensive chemotherapy for transplant. Or older patients with a poor performance status, you can use a hypomethylating agent plus ruxolitinib, and then to transplant, look for mutations, clinical trial, or supportive care. And that is kind of what we'll talk about today. So, what about the hypomethylating agents alone? These can be used with or without a plan for transplant. We have a few that we could use, and they're distinguished sort of by their the way that you give them, really. Otherwise, they're not too different from each other. So, azacitidine, also called Vidasa, is given subcutaneously, so as an injection for 7 days every 28 days. This is typically given in clinic. It's not something you give at home. You would come to clinic to get it. And the side effects are pretty mild. People can have some injection site reactions, gastrointestinal side effects, and low blood counts. Um, Overall, a really well tolerated medication. Decitabine is very similar to azacitidine. It's given IV, similar side effects. We now have an oral version of decitabine. Where they added an enzyme called sidaziridine to help increase the blood levels of the decitabine when given by mouth. And it's given for 5 days every 28 days. And it has pretty similar effects to the IV one. Sometimes we see a little bit lower of blood counts with the oral decitabine. So we can use these. What are the outcomes with using single agent hypomethylating therapy? We do have room for improvement. Hematologic improvement rates, which is meaning improvement of blood counts, does occur in about 50 to 60% of the people, which for many people is very helpful. However, rates of remission, complete remission, meaning you clear out all the blasts in the marrow and all the blood counts improve, are low, 10 to 20%. And the rate of transplant is low, just looking at a couple of transplant studies for patients with MPN and accelerated or blast phase. In this trial, 30% of patients went to transplant after decitabine, and this one, only 1% went to transplant. And that's probably because of somewhat low rates of disease control. What about induction or intensive chemotherapy? So the classic type of induction chemotherapy is called 7+3, which is 7 days of a drug called cytarabine and 3 days of a drug called an anthracycline. We also have high dose cytarabine based regimens, which we will often use here at this center, in case you're a patient here. And how successful is induction type chemotherapy in changing the outcomes of accelerated and blast phase? We're not sure. This is a really older curve, but the induction chemotherapy seemed to have no impact on survival. And intensive therapy is challenging in patients with underlying fibrosis in the marrow because intensive chemotherapy basically ablates the whole marrow. It gets rid of everything in the marrow. And then the normal stem cell is expected to come back faster than the cancer stem cell and produce good blood counts. But when you have scar tissue or fibrosis in the marrow, this can take a lot longer. So people have low blood counts for longer, at higher risk for side effects from low blood counts like infections and bleeding. And the big spleen that is often present can complicate our need to give transfusions to people. So this is a challenging approach. What adjuncts can we add to improve responses to either backbone, either the hypomethylating agent or the cytarabine? So we could add JAK inhibitors. So now we have 4. As Dr. Salat discussed, peri-transplant ruxolitinib has been associated with positive outcomes. We can use targeted therapy, IDH and FLT3 inhibitors. We could use venetoclax, and we have clinical trials. And particularly in the case of TP53 mutated disease, which is a higher risk mutation, we always try to find a patient a clinical trial if we can. So this is just, we have very little data actually for combination therapy before transplant. There was a trial with 6 patients with 7+3 with ruxolitinib, and half got to transplant. HMA plus ruxolitinib has been evaluated in quite a few trials. Response rates range 24 to 72%. Low blood counts continue to be an issue. If you remember that ruxolitinib can be a little bit myelosuppressive, which means it leads to low blood counts itself. I do have a clinical trial here that is particularly for patients with MPNs in accelerated or blast phase who are going to transplant, and it combines decitabine with a JAK inhibitor. There is some data that shows these are synergistic drugs or help improve each other's the way that they work. In this case, in this trial, decitabine is given IV for actually 10 days for every 28 days, the first 2 cycles, and then you could add either ruxolitinib, fedratinib, or pacritinib. And so we do bone marrow evaluations every 2 cycle, and we move patients to transplant at the best response. And then there's a lot of peri-transplant ruxolitinib trials for myelofibrosis, which you can find on our website or on clinicaltrials.gov as well. And I just listed a couple of those, both of Dr. Salet's. So what about MDS transformation? So I think Dr. Caraway is going to get through this a little bit. So MDS is another clonal myeloid bone marrow disorder. And we have risk scores that predict the risk of transformation. And particularly to AML or acute leukemia, we had the IPSS-R, now the IPSS-M. And the risk, it really ranges from the very low risk group to most people don't progress to less than a year for patients in the very high risk group. So it can be an issue. I won't go through that very much because I think she's going to, but our IPSS-M now also predicts who is at highest risk of transforming to acute leukemia and when is it expected to happen. And so this is the sort of leukemia-free survival probability. When do people transform? And this green line is very low risk, and the red line is very high risk. And there's 50% of the median, about half the people. So in the very high risk group, about half the people are transforming to acute leukemia by a year. In the very low risk group, most people have not transformed, or almost all, by 10 years. Okay, so this is really variable. Secondary AML, which is AML that arises typically out of MDS or MPN, is more challenging to treat than de novo AML. And again, for MDS, the only curative therapy is allogeneic stem cell transplant. And therapies range from supportive care to hypomethylating agents and induction chemo, also for MDS. So really, it's pretty similar for MPNs and MDS who transform. The difference in MDS is you don't have the big spleen and constitutional symptoms. And again, for MDS, mutation panel should be done at progression to broaden treatment options. So what are our therapy options for MDS when it transforms to AML? Again, we can use HMAs alone, targeted therapy, venetoclax. I'm going to talk about a drug called Vyxeos, induction chemotherapy, and stem cell transplant, going sort of from lowest to highest intensity. How do we choose? We've been talking a lot about shared decision-making. This is a shared decision-making situation. It depends on the age and health of the patient, the comorbidities, the goals of the patient, and sort of transplant options. So what about azacitidine and venetoclax? So this in AML improved remission rates and survival. So venetoclax is a small molecule BCL2 inhibitor. And this was the sort of foundational trial in leukemia where 430 patients who were elderly or had comorbidities with leukemia. So this included patients who had secondary disease, who transformed out of MDS or MPN, were randomized to azacitidine, we talked about with venetoclax, that's an hypomethylating agent, to azacitidine plus placebo. And this is the survival probability. So the hazard ratio for death was 0.66 in the combination arm, meaning a lower risk of death. And the median survival, the average survival in the combination arm was about 5 to 6 months longer in the combination. And this really led to the establishment of this drug to be really a critical player in this field, although it doesn't sound like that's that much, 5 or 6 months overall survival. It really can increase the response rate to this regimen. And so this is just looking at particularly patients who have transformed potentially out of MPNs or MDS, and how do they do? So this side of the line, this dotted line, means that the azacitidine and venetoclax was better in that subgroup. This is a subgroup analysis. And on this side of the line, it showed azacitidine plus placebo was better. So focusing on the type of AML, de novo means it did not transform out of something. Secondary means it did. So patients with secondary AML also did better. See, this little black dot is the sort of that hazard ratio. And that is well to the side of this line, and it doesn't cross over this line, which would mean we weren't certain it did better. So the hazard ratio for death was still 0.56. And then AML with myelodysplasia related changes, that is AML that also might have transformed out of MDS, or it has features that are really similar to MDS. And again, patients generally did better, although that one does cross the line. So it was not as certain, but it was probably a much smaller subgroup. Then to chat briefly about Vyxeos. So Vyxeos is approved for AML also with myelodysplasia related changes. It is a liposomal encapsulation of that 7+3 that I talked about, which is the standard of therapy for AML. And that means it's encased basically in fat. And so when those drugs are incorporated into the bone marrow, they actually stay there for longer and expose the blast to the chemotherapy for longer. It was approved in 2017 based on this phase 3 trial where patients were randomized to Vyxeos versus 7+3, and the overall survival was better in the Vyxeos arm. So that is another option for patients. And then I just wanted to include a lot of clinical trials over here. As I said, we have a lot of room for improvement in this population. It can be challenging to treat. So we really would love to give people access to clinical trials and figure out a better way to treat these diseases. So if you ever have not used clinicaltrials.gov, you can search by disease, you can search by location or state, and it can tell you whether trials are open and recruiting and give you general eligibility criteria. We have a bunch of non-transplant trials for AML, and then there's all the transplant trials as well.